Hello. Today we're gonna get chapter 4 of 5 that we talked about. Okay, so let me move so I can see what I'm doing. Okay, so we are on chapter 5, so we can get that posted and get get you going and moving forward. So we have recommend diagnostic procedures. So we're gonna recommend them, right? So this is also an important part of your exam. Remember that when they have 8 questions, it's a very important part. So you've got 2 recall for application and 2 analysis. And what you need to know in this essential content, testing for TB, we should know what we need to do for that. We've talked about that quite a few times. We always recommend that TB skin test for high risk people with TB. Those who have symptoms such as high fevers, night sweats, cough, or weight loss, we know that they'll become cachetic. Or someone who's exposed in their family with TB, or in a country who has low, you know, oh gosh, that are in a low thriving country such as Latin America, Caribbean, Africa, Asia, Eastern Europe, or Russia, or those who live or work somewhere in the U.S. where TB is most common, such as homeless shelters, prisons, or jails, and some nursing homes can spread. A lot of people with HIV are a higher risk, and those who do illegal drugs. You can do the interferon gamma release assays. That's the IGRA, which is as sensitive as the Manitux test for detecting latent TB and more sensitive detecting active TB. That's the blood test that measures how the immune system reacts to the Mycobacterium tuberculosis. There's also skin tests for allergies for those IgEs that are also hyperinsensitivity reactions to environmental food or allergens. It helps you know for allergic asthma, rhinitis, or conjunctivitis, food allergies, drug allergies, um, penicillin, venom allergies, bee or wasp stings, which is good. They will ask you, maybe you would want to know that if you were doing an asthmatic patient in your CSE. A skin test should not be performed routinely on patients at high risk for anaphylactic reaction. The reason for that would be as if you're sitting there not monitoring them, what would happen is they would have a reaction and their airway could swell up, right? Or those taking medications that interfere with the IgE immune response, so antihistamine, steroids, or antibodies such as Xolair that treat asthma. Recommended blood tests that you would want patient scenarios such as patients with evidence of tissue hypoxia but normal PO2 and SPO2. That would be people that have a hemoglobin and hematocrit to determine O2 carrying capacity, um, hemoximetry to assess for actual SaO2 and abnormal saturation. Then you have a post-op patient with low-grade fever. So you would want to look at their white blood cell count with differential to rule out possible bacterial pneumonia. We've talked about these. I can't really see why we need to go over that, but post-op pain, we want a D-dimer to look for what? We would want to look at maybe a remember D-dimer goes with blood clots, right? That would be going with a um, pulmonary embolism. They could have an ischemic modified albumin, ABGs to assess for the degree of hypoxemia. Patients with a fluid balance disturbances, we always want to get electrolytes to make sure to see their inputs, their outputs, and also look at their potassium, um, chloride, all that good stuff. Patients with decrease of less than 25 mils per hour or absent urine output over time, we're going to look at electrolytes. We want to look at urinalysis gravity. This is when we're going to want that bun. I know we talked about a BMP yesterday, but this is when we're going to want to look at a bun because that'll tell us about their creat and getting a creatinine. That would help make a decision on a renal failure disease. Patients with chest pain, likely due to myocardial infarction or ischemia, we need to look at those cardiac biomarkers such as CK, CKMB, troponin. Patients with suspected hepatitis, such as liver enzymes, to assess liver function. Selected drug screening panels, history of alcohol. Patient with acid disturbances, we know that we should definitely get an ABG, possibly electrolytes, albumin, total protein, bilirubin. Patients with unexplained muscle weakness, definitely get some electrolytes. They could be dehydrated. Um, Look at their potassium, for glucose. They could be hypoglycemic. Thyroid could be bothering them. Patient with premature ventricular contractions or cardiac dysrhythmias. Electrolytes, we would definitely, I know we're not talking about a blood test, but we'd want to get a EKG on that. Patient on anticoagulants therapy or with uncontrolled bleeding. Platelet count, obviously, coagulation studies, so INR, PTT, hemoglobin, hematocrit, red blood cells. Patient with shock-like symptoms, so cardiac biomarkers, renal function test, blood culture, hemoglobin, hematocrit, lactic acid for sure. And when we recommend imaging studies, so if we want to look at evaluate the signs and symptoms of respiratory and cardiovascular disorders. So follow known chest disease processes to assess progression, monitor patients receiving vent support, monitor patients after thoracic surgery, confirm proper placement of ET tubes. So we need to look at the ET tubes, the CVP, the pulmonary artery catheter, or Swan scans, because you're going to hear it both ways, the NG, the OG, and the chest tubes. Comply with government requirements for chest x-rays as an occupational lung disease. So we're going to look at that. So we're going to recommend to follow all these processes, okay? Comments would be to, although performing a chest x-ray after a thoracentesis is common practice, the American College of Radiology recommends it only if a pneumothorax is suspected. So if air rather than fluid is aspirated. So if you're doing a thoracentesis and you're taking out air for a pneumo instead of fluid, because being able to see that fluid routinely is not going to be the best way. You're really going to have to go a different route, right? So perform a chest x-ray only when indicated. Routine daily chest x-ray is no longer recommended to monitor mechanically ventilated patients. It's not really, it's not recommended. You don't have to do that. If your patient is stable on a mechanical ventilator, there's really no point. You see the ET tube in line, it's not moving, it's staying at position. The only reason that you maybe would want to get another x-ray, you would order the x-ray based on changes, or you're trying to see improvement of a pneumonia or a pneumothorax or something like that. You wouldn't do it routinely, is what they're trying to say. So you would only recommend it to, okay, well, 12 hours later, hey, how are we doing our pneumo? Or hey, next day, how are we doing our pneumo? Or how are we doing on our pneumonia? So forth. Next, neck x-ray help diagnose causes of stridor and respiratory distress. So detect the pressure of radiopec aspirated foreign bodies. So did kiddo get a coin or toy? Detect retropharyngeal abscesses and hematomas. So hematomas mean blood. So AP versus lateral neck films are taken to differentiate croup from epiglottitis. Okay. So however, the classic AP view, which is the steeple, right? AP view is a steeple sign. Okay. Described for croup is not specific to that disorder and may be absent. Okay. So you need to know the difference between those two. And thoracic computed, so CT, always start. So CT scan. So evaluate abnormalities identified by chest x-ray. So in ILD, pleural effusions, and pulmonary nodules. Stage lung cancer, detect tumor metastasis to the lung, detect mediastinal masses, nodes, and other abnormalities. Pulmonary embolisms, or you could do a spiral CT and CT angiogram, which is recommended along with a D dimer, okay? detect and evaluate aortic aneurysm, assess trauma to thoracic organs and structures. Your patient should be remain motionless because we got to go in and out of that CT machine, and they don't want you to move. Okay. A spiral CT and CT angiogram are replacing those VQ scans that are older for diagnosing that pulmonary embolism. Then you have an MRI, so we want to evaluate the heart, the major vessels, and lungs for pathologic abnormalities, and assess the chest wall and surrounding soft tissues for abnormalities. Evaluate posterior mediastinal masses, detect and evaluate aortic aneurysms, detect, assess mediastinal vascular and chest wall metastasis of cancer, stage lung cancer in patients who are allergic to radiographic contrast media. So those patients must remain motionless for longer periods of time. So these patients really need to be stable. Some people get very claustrophobic, so we might have to give them some Ativan. We might have to give them some type of sedative to get them very stable, a Xanax, something like that, to be able to relax. It is contraindicated in patients with pacemakers, metallic surgical clips or heart valves, or infusions of chemotherapy pumps. So vent support must be provided by manual or plastic resuscitators or via ventilators certified for MRI use. So you might, if you don't have a transport vent that's accessible, you might have to sit there and bag them the whole time. A lot of times we've had to bag in CT. So in CT, you just sit there and bag them. MRI is less accurate than a CT for assessing lung parenchyma diseases. So it's a lot easier just to send them in for a CT for anything to do with the lung because they can take a deep breath in, deep breath out, and it's much easier. So post-run, so a PET scan, we talked about this, I think, yesterday. So differentiate malignant versus benign masses. So assess tumor metastasis response to therapy. Determine tumor biopsy sites. Detect and localize impaired blood flow to the myocardium. So often combined with a CT scan. So you would have both. First, you're going to recommend one, and then they say, okay, we're going to have to send you for this to enhance diagnostic accuracy. It's most common use in pulmonary medicine to diagnose, stage, and evaluate treatment of non-small cell lung cancer. And if you remember, I believe it was it Stormy that had this disorder or disease? Can't remember which one of y'all had this. But when you went into detail, the difference of what a PET scan tells you, remember we got you heat and we went over these in disease class, and you see the different disorders. You can go back to those slides and look, and it shows you the different slides of what the heat and what it shows you. You'll see those nodules, okay, in their lungs. So, okay, so pulmonary angiogram. That's to evaluate the pulmonary arteries for PE, stenosis, AV malformation, or aneurysm. It's contraindicated in patients with bleeding abnormalities, extremely high blood pressure, or shock. And like I said, it's going to be replaced with your CT angiography because that's for your PEs. A VQ scan, so it's ventilation perfusion. Remember, it's going to tell us about ventilation perfusion. It's to detect and quantify the size of pulmonary embolism. Assesses a regional pulmonary blood flow in patients undergoing lung resection surgery. Okay, so lung resection. So is going to be good for that, as patients must be able to breathe through a mouthpiece, hold the breath for 10 seconds or more, and remain still during this procedure. And then you have transthoracic ultrasound. So you've probably heard of this, okay? And it's to detect free fluid in the thorax, so your pleural pericardial effusion or your hemothorax. It detects pneumothorax, mediastinal masses, pulmonary atelectasis or consolidation, assesses pleural surfaces for pleuritis or granulomatosis processes, thoracic wall lesions and rib masses, trauma to the diaphragm, heart, and large thoracic vessels, as well as bone fractures. It guides thoracentesis and percutaneous needle biopsies, and it's generally ineffective in imaging tissues or organs through aerated lung tissues or pneumothoraxes. So why are we going to have indications for a diagnostic bronchoscopy? Diagnostic. Remember, you have therapeutic and diagnostic. We're going to talk about diagnostic right now. So diagnostic means we are trying to diagnose something and find what's wrong, okay? So we're going to assess lesions of unknown etiology that appear on a chest x-ray. We're going to evaluate recurrent atelectasis or pulmonary infiltrates. So this is people that are constantly having something wrong with them. Assessing the patency of the upper airway. We're investigating the source of hemoptysis. So they're bleeding in their airway and it's continuous. So we need to find out why. So we're going to diagnose that. We're evaluating unexplained cough, localized unilateral wheeze. Maybe they have a stridor. We're following up with a suspicious or positive sputum cytology results. We're obtaining lower up respiratory tract secretions, cell washings, or biopsies for cytologic or microbiologic assessment, and we're determining the location and extent of injury from toxic inhalation or aspiration, and we're evaluating problems associated with artificial airways, for example, tube placement or tracheal damage. So this is diagnostic. So now we're going to talk about therapeutic. Therapeutic, we're trying to help them better, okay? So we're trying to treat, okay? So this is facilitating our therapeutic or doing something to make them better, okay? So facilitating ET tube insertion during a difficult intubation. So we couldn't do it with our regular stuff, so we're having to help facilitate this with this, okay? Achieving selective intubation of a mainstem bronchus, locating and clearing mucus plugs causing lobar and segmental atelectasis, removing abnormal endobronchial tissue or foreign bodies, the need to place and assess airway stent function, the need for airway balloon dilation, and the treatment of tracheobronchial stenosis. So locating and clearing mucus plugs, so that means they could do a wash, okay? Contraindications. So according to the AARC, you should recommend against bronchoscopies in a patient who meet the following criteria. You cannot be adequately oxygenated during this procedure. So if they cannot be, we would not want to do that. I mean, we would also obviously try to find a way if we couldn't, if they couldn't be intubated and be off the vent, or we couldn't find a way to keep them oxygenated while we were doing this, then we would have to wait and hold off if they're not stable enough. Okay. Have a bleeding disorder that cannot be corrected, so we couldn't stop them bleeding, or they would bleed by barely even touching them or doing the bronchoscopy, and it made it worse, then we wouldn't be able to do it. Have a severe obstructive airway disease, so we would be more obstructing them by going in, right? So we would be putting more pressure into that. Have severe refractory hypoxemia, or hemodynamically unstable. So a bronchial alveolar lavage, so it involves the installation or removal of sterile saline solution, a lung segment via the suction channel of a fiber optic bronchoscope. So that's what I was talking about. They can go in there and wash out. The withdrawn fluid then undergoes chemical, cytologic, and or microbiologic assessment, and is indicated in patients with non-resolving pneumonias, unexplained lung infiltrates, or suspected alveolar hemorrhage, and is a key tool for diagnosing BAP and can be helpful confirming some lung cancers, and it's a major contraindication to bowels of predisposition and bleeding. We have just went over this quite a few times, so I'm not going to get into this. So recommended PFTs, we know why we should do this. We've talked about this quite a few times. And you have this box. So I think I might want to say something about... Okay, indications for various invasive and non-invasive blood measurements. So ABG, we know that we are going to indicate that whenever we see if it's invasive, because we want to evaluate their ventilation, their acid, their oxygenation status. We want to assess the patient's response to a therapy or diagnostic test. So even if they're doing O2 therapy, exercise testing, we want to monitor the severity and progressive of documented disease processes. So that means even if like they were long-term therapy and we were treating them for anything. Hemo-oximetry and co-oximetry. I think that we were talking about this yesterday and we were getting a little confused. So this has to be this is an extra test, okay? Hemo-oximetry or co-oximetry, okay? It doesn't come on the ABG. You have to order this separately, okay? So if you suspect that your patient has some type of issue that needs to be looked at, such as if they were having a chemical disorder or so forth, then you would have to chemical inhalation or a smoke inhalation, sulfur hemoglobin, something like that. You would have to order a co-ox, okay? So to determine the actual blood oxyhemoglobin saturation, you're going to have to order that co-ox, okay? Measure abnormal hemoglobin levels, and it's going to be carboxyhemoglobin, which is hemoglobin, CO, methemoglobin, or sulfur hemoglobin. So a non-invasive measurement is pulse ox, which is SpO2. So monitor the adequacy of SpO2 and quantify the response of SpO2 to therapeutic or diagnostic interventions. Screen the critical congenital heart disease in neonates. So a dual oximetry. Comply with regulations or recommendations by authoritative groups. Transcutaneous monitoring, we've talked about this quite a few times now. So that's continuous monitoring for excess arterial oxygenation. Quantify real-time changes in capnography. That's invasive and non-invasive. So you can confirm proper placement of the ET tube during intubation. That would be invasive. Monitor patients receiving moderate sedation for opioid analgesic suppressions. So that's non-invasive. So you actually could do that on a nasal cannula. Monitor the effectiveness of compressions during CPR. So capnometry only. So that's invasive. Assess the metabolic rate. So non-invasive and invasive. Oops, wrong button. So if the goal is the most accurate evaluation of oxygenation, ventilation, and acid-base status, always recommended an ABG. So standard ABG analysis does not measure actual HB content. So you're not going to see your hemoglobin content on a regular ABG. All you're going to get is your pH, your CO2, your bicarb, your SaO2, your PaO2, and your base excess. That's all you're going to get on an ABG analysis. You have to order everything else separate. Your electrolytes, your carboxyhemoglobin, and so forth. So it does not measure your HB content, your HB saturation, or abnormal hemoglobin, such as carboxyhemoglobin. If you need accurate measurements of any hemoglobin parameters, use or recommend hemo-oximetry. So the most common patient scenario in which you should recommend hemo-oximetry is smoke inhalation or CO poisoning. You should recommend hemo-oximetry when you need to calibrate a pulse oximetry reading against the actual arterial saturation. So pulse ox should never be substituted for a ABG analysis or hemo-oximetry when the clinical situation demands accurate assessment of oxygenation. You need to recommend against pulse ox in patients with poor peripheral perfusion and when there is a need to monitor for hyperoxemia, so higher than normal PO2s. Talk about that. Monitoring. I think we're trying to. So indications for EKGs, screening for heart disease. So we know that's what we're usually doing that for, right? So coronary artery disease, so CAD, or left ventricular hypertrophy. Hypertrophy means large, right? Ruling out heart disease in surgical patients. So we want to make sure that we always do an EKG before we do a lot of surgeries because they want a baseline. Evaluating patients with chest pain, following the progression of patients with CAD, evaluating heart rhythm disorders by using rhythm strips. A 12-lead EKG can also be used to assess the effect of metabolic disorders associated with electrolyte disturbances, in particular, a calcium and potassium imbalances. So exhaled CO analysis is indicated to monitor patient smoking status. So reading below 6 to 8 parts per million signify a non-smoking status, with values of 3 to 4 parts per million typically confirm true smoking absences. So reading above 6 to 8 indicate that smoking has likely occurred within the past 12 to 24 hours. So we look at this, okay, based on if we were trying to do pulmonary rehab with a patient or we were doing smoking cessation. So you might have a question about this. So if they had an exhaled CO and it's above this and they've been trying to stay abstinence from smoking, and then all of a sudden it starts reading above that and they were doing pulmonary rehab or smoking cessation, and then so in the last 12 to 24 hours it occurred above that, then you know that they are smoking again. So a higher cutoff of 10 to 11 parts per million should be applied to the patient with inflammatory lung diseases such as asthma or COPD, because inflammation boosts endogenous CO production. So exhaled CO analysis is also indicated to assess for moderate levels of CO poisoning in conscious and cooperative patients. So divide the CO concentration in parts per million by 6 to estimate the carboxyhemoglobin percent. For example, and an exhaled CO reading of 48 parts per million will indicate a carboxyhemoglobin saturation about 8%. So if you had a patient that was doing 10 and then you times it times 48, wait, what are they doing? Divided. Oh, they divided it. Okay, so 10 divided. Okay. Okay. So FeNO, so you got fractional exhaled nitric oxide analysis. Okay, so nitric oxide is a chemical mediator produced primarily for endothelial cells in the lung, as well as by the epithelial cells, macrophages, eosinophils, and neurons. It is a gas, so NO appears in the exhale breath, with its concentration increasing in the presence of the airway inflammation. So this is usually with patients with asthma. So this is usually an asthma question. It's exhaled NO analysis can be helped establish the corrected diagnosis. So in those with confirmed asthma diagnosis, you can recommend exhaled NO analysis to do the following: predict the response to corticosteroids. We had a question yesterday about this. Okay, this is going to predict the response to corticosteroids, titrate anti-inflammatory medication, monitor the level of asthma control, predict impending exacerbations, and monitor medication adherence. It cannot reverse or show reversal of disorder. Obviously, we wouldn't see a reversal of asthma or whatever, but you cannot see that. The only thing that would predict that or see that, you'd have to do a full PFT. So exhaled NO levels and key patient management points. So remember that you have an adult low would be less than 25 parts per billion, and then your intermediate, and then your high. Children is about, it looks like there's 5 on the low side, and then a 5 difference, except for their intermediate is 35. So and then you have eosinophilic inflammation. So is it unlikely, likely, or present? And management points, you want to look at your symptomatic. So is your inhaled corticosteroids going to respond or not? So, and so forth. So non-invasive blood pressure measurement, we know we're just going to do, it's a component of vital signs. Blood pressure should be measured. The frequency of measurement varies according to the patient's cardiovascular stability, and automated non-invasive bedside system allows you to do it every 5 minutes. And then you have your indwelling catheter. So you're going to have a line. It does continuous monitoring, and then you can do frequent ABG labs for respiratory failure or mechanical ventilation. Contraindications for that would be inadequate collateral arterial circulation, evidence of infection or peripheral vascular disease, severe bleeding disorder, presence of surgical dialysis shunt. So we talked about shunts. You don't want to do it in the arm that has a shunt, possibly even if that patient had breast cancer on that side. So CVP monitoring, remember the central venous pressure, they can have a CVP monitoring. So to monitor CVP, right ventricular function in unstable hypotensive patients, we want to do it because we want to provide and monitor volume resuscitation. We can infuse drugs that can cause peripheral phlebitis, certain vasopressors and chemotherapeutic agents. We can use it to sample blood for PbO2 and SpO2. So remember on your CVP, you can get your venous measurements, okay? Your mixed venous measurements. It's to provide a route for total parental nutrition, to perform plasmapheresis or hemodialysis, to introduce transvenous pacing wires, to provide venous access in patients with poor peripheral veins. Contraindications is evidence of infection at the insertion site, abnormalities at the insertion site, suspected injury to the superior vena cava, severe bleeding disorder, presence of intravascular pacemaker or vena cava filter, severe obesity can be a problem, embolus lung disease. Pulmonary artery catheter, which Swan-Ganz, is to identify the cause of various shock states. It can help identify causes of pulmonary edema. So pulmonary artery catheter, that's going to give us our pulmonary wedge pressure, our pulmonary artery pressure. So this is really important on pulmonary edema, pulmonary hypertension, vascular disease, intracardiac shunts, cardiac tamponade, pulmonary embolism, to monitor and manage complicated MIs, assess hemodynamic response to therapies, manage multiple organ failure, manage hemodynamic instability after cardiac surgery, to optimize fluid and inotropic therapy, to measure tissue oxygenation and cardiac output, perform atrial and ventricular pacing. Contraindications are certain dysrhythmias. Oh, that scared me. Tricuspid or pulmonary valve endocarditis stenosis or mechanical prosthesis, right heart mass, infection at the insertion site, the presence of an right ventricular assist device, severe bleeding disorder. So overall oximetry indications, so they should be recommended for the following purposes: as to identify SAHS, helping assess response to sleep apnea, identify whether serious desaturations occur in patients with COPD, for in-home assessment sleep disorders overnight, for oximetry that has largely been replaced by limited polysomnography, limited PSG monitors up to 7 key parameters, including SpO2. Respiratory effort is recommended for individuals who have high likelihood of obstructive sleep apnea. Is also recommended follow-up effectiveness of treatment. When screening COPD patients for nocturnal desaturation, the focus should be on those with hypercapnia, erythrocytosis, or evidence of pulmonary hypertension. Indications of laboratory polymorphismography. So COPD with a weight PO2 less than 55, and those whose condition includes pulmonary hypertension, right heart failure, and polycythemia, or excessive daytime sleepiness. You can have chest wall or neuromuscular restrictive disorders, and whose condition includes chronic hypoventilation, polycythemia, pulmonary hypertension, disturbed sleep, morning headaches, daytime somnolence, and fatigue. Disorders of respiratory control with chronic hypoventilation, so daytime PaCO2 greater than 45, or whose illness is complicated by pulmonary hypertension, polycythemia, disturbed sleep, morning headaches, and daytime somnolence. Excess daytime sleepiness or sleep maintenance, insomnia, snoring associated with observed apneas, or excessive daytime sleepiness. Lab PSG also is indicated to help diagnose certain neurologic movement disorders such as restless leg syndrome, nocturnal seizures, Wells parasinomias, such as sleepwalking. It can also assess the adequacy of sleep-related interventions such as you want to titrate your CPAP, bi-level positive airway pressure in patients with sleep apnea, determining BiPAP levels for respiratory insufficiency due to chronic neuromuscular disorders such as amyotrophic lateral sclerosis. So why are we going to do a thoracentesis? So is a physician-performed procedure involving withdrawal of fluid from the pleural space for either diagnostic or therapeutic purposes. A diagnostic thoracentesis is indicated to help determine the causes of the accumulated fluid in the pleural space. So you can have transudative versus exudative. So, or to obtain cell samples to assess for certain malignancies. So recommend a therapeutic thoracentesis for any patient with a pleural effusion large enough to cause respiratory distress.